Hello, welcome to the e-classes. Last day we discussed about peptic ulcer disease, and during discussion we mentioned the complications of peptic ulcer. There are three complications, as you know. One is GI bleeding, upper GI bleeding. Number two, peptic perforation. Number three, gastric outlet obstruction. Today, I will take up upper GI gastrointestinal bleeding. This is the most common intestinal bleeding is a most common clinical problem resulting in comorbidities and death. GI bleeding can be divided into upper GI bleeding and lower GI bleeding. It is the ligament of trees at the junction of duodenojejunum which demarcates the upper GI bleeding from lower GI bleeding. Above this ligament, that is from the esophagus, stomach and duodenum, the bleeding we call upper GI bleeding. And below this ligament, the bleeding from the jejunum, ileum, the large intestine, colon, rectum, all are lower GI bleeding. Now, upper GI bleeding may be either overt or occult bleeding, which we can see, that is overt bleeding, which we cannot see but there is bleeding, that we call occult bleeding. Overt bleeding may be manifested by, number one, hematemesis, means vomiting of blood or coffee ground blood materials, hematemesis, or number two, melena, that is black, tarry, foul-smelling stool, and hematochezia, that is passage of bright red or maroon colored blood from the rectum. So, bleeding may be hematemesis, melena, or hematochezia. Hematochezia is characteristically come from the lower GI bleed. Sometimes, very rarely, it comes from the upper GI when there is bleeding is profuse and rapid. Commonly, hematemesis and melena, these are the two characteristic features of upper GI bleeding. Occult GI bleed patients present with symptoms of blood loss or anemia such as lightheadedness, syncope, angina and dyspnea, or routine diagnostic evaluation reveals iron deficiency anemia or positive occult blood test. Now, what are the common causes of bleeding? You know, the stomach has got the lesser curvature ulcers and the duodenal ulcers, which I have mentioned in my last lecture. So, this together called is peptic ulcers. So, this bleeding may come from the peptic ulcers, this is very common. Bleeding may come from the varices in the esophageal, that is esophageal varices, or it may be due to malorifious tear. There is profuse vomiting, retching that will give rise to tear in the lower end of the esophagogastric junction, that is we call malorifious tear. Then it may be due to gastric erosions, gastritis or duodenitis, and some drugs, particularly non-steroidal anti-inflammatory drugs and aspirin, and sometimes steroids that can give rise to bleeding. Then the diseases of the esophagus, esophagitis, and another important cause is gastroesophageal reflux and gastric carcinoma and esophageal carcinoma. So these are the common causes of upper GI bleeding. I want to repeat: peptic ulcer, esophageal varices, malorifious tear, gastric erosions, drugs, NSAID, aspirin, esophagitis, gastroesophageal reflux, gastric carcinoma, and esophageal carcinoma. There may be some rare causes of bleeding also. In this bleeding, I have not mentioned the most important cause is your portal hypertension. that should be taken separately. That's why I have not mentioned here. There may be some rare causes, bleeding disorders, portal hypertensive gastropathy, Wechsler-Weber-Rendu syndrome, and angiodysplasia. This is not important for MBBS students. So now you look at this picture. Here the causes of this GI bleeding has been depicted by a very nice picture. You see, this is the esophageal varices. So this causes, esophageal varices causes up to 9% of the GI bleeding. Portal vein thrombosis, cirrhosis of liver with portal hypertension. Then there may be esophagitis that also causes 10% of hiatus hernia associated bleeding. Then peptic ulcer disease, this is duodenal ulcer, this is gastric ulcer with a lesser curvature. Both these together comprise 35 to 50% of the upper GI bleeding. It may be caused by also cancer of the stomach, here it is depicted. Then NSAID and alcohol that cause gastritis, gastric erosions that can give rise to 10 to 20%. And very rare causes of vascular malformations and aortoduodenal fistula. This is not important. The two causes you must remember, one is bleeding peptic ulcers, duodenal ulcers or gastric ulcers, and variceal bleeding, esophageal varices. In this connection, I would like to mention the lower GI bleedings. These are some of the causes just mentioned, but we will not discuss today lower GI bleeding. Common causes are ulcerative colitis and Crohn's disease. Together we call inflammatory bowel disease. Then it may be due to rectal bleeding, hemorrhoids, fissures, large polyps, colonic CA or rectal CA, and diverticular disease or solitary rectal ulcers. So there is a difference between this upper GI and lower GI bleeding. I have already mentioned that hematochezia is characteristic of lower GI bleeding. It is acute and profuse and stops spontaneously, lower GI bleeding, but upper GI bleeding usually gives rise to hematemesis, that is coffee ground color. The blood is mixed with the digestive enzymes and hydrochloric acid that give rise to this color. Melena is a blood loss in the GIT more than 40 hours, more than 14 hours, and it is also mixed with hydrochloric acid and enzymes and the bacteria that give rise to characteristic features of this melena. It is foul smelling and tarry stool, sticky. Then if we examine, there may be some hyperactive bowel sounds. So most important thing is the diagnosis, is the initial assessment of upper GI bleeding. So you have to take history, and the history you have to take the drug history, whether patient has received NSAID or aspirin like that. Then you have to examine the circulatory status, very important. And in the circulatory status, the tachycardia, more than 100 pulse rate, and hypotension, blood pressure less than 100, and cold extremity with oliguria, all this together causes the patient is in shock, and there is severe upper GI bleeding giving rise to shock, and this patient needs special treatment immediately before going to investigations. So circulatory status, then we have to look for whether there is evidence of chronic liver disease. If there is evidence of chronic liver disease, so the bleeding must be from the esophageal varices. So we have to look for jaundice, hepatomegaly, ascites, like that. And also, if possible, we have to look for the comorbidity, whether a patient is a case of old stroke or CKD or ischemic heart disease who is receiving aspirin or like that, or COPD. So there are certain risk stratification in the assessment of how much the upper GI bleeding is severe or mild or moderate. So there are certain names of these modified scores. One is modified Blackford's score, that is the following factors: anemia, blood urea, and systolic blood pressure. These three factors will determine whether the patient is in severe upper GI bleeding. If patient is severely anemic and the blood urea rises, but creatinine is normal and there is systolic blood pressure less than 90 or less than 100, this naturally patient is in severe bleeding. This is interesting that in patients of upper GI bleeding, patient does not cause anemia right now, because it will take some time for this blood loss or the fluid loss to be corrected from the extracellular fluid. That's why anemia will occur after 2 to 3 days. The next thing is the assessment of fluid and assessment of blood transfusion. So if the patient is severe bleeding, we have to give some fluid. So a wide bore needle, IV fluid to be started, normal saline, and arrangements for blood transfusion to be sent for, and along with we can give IV PPI, proton pump inhibitor, and along with resuscitation, and blood transfusion needed is packed cell RBC. So all these arrangements to be done side by side. We are assessing the patient and going for some investigations. So we'll go for some baseline investigations also. The baseline investigations will dictate whether the patient is having some comorbidities or others that I have mentioned. So fluid blood count is important. There may be anemia found in chronic and subacute bleeding. Hemoglobin concentration may be normal after sudden major bleeding, I have mentioned, until hemodilution occurs. Then urea will rise. So this rise of urea with normal creatinine will indicate that there is bleeding in the GI tract. This blood is absorbed, that's why the blood urea is raised. So we can also do some liver function tests and prothrombin time for coagulator profile. So let us recapitulate the management of upper GI bleeding, non-variceal bleeding. We can divide it a variceal bleeding and non-variceal bleeding. So what I have talked right now is assess the amount of blood loss, then check the pulse, blood pressure, CVP. If BP is 100/60, pulse is more than 100. IV fluids is normal saline, arrange for blood transfusion if needed. Blood when the patient hemodynamic is stable, and IV omeprazole 80 mg as a bolus dose, and then continue IV 8 mg per hour for 3 days. And vitamin K can be given if it suggests that the variceal bleeding is there, and arrange for endoscopy. Endoscopy is a highly diagnostic accuracy. 80% cases we can dictate whether bleeding is from the peptic ulcer, bleeding peptic ulcer, or from the esophageal varices. And it can also have some therapeutic role. Through endoscopy we can do something that bleeding can be stopped. Then is the monitoring. So once the patient has been stabilized, patient has been given IV fluid, blood pressure is rising, we have to monitor, and the blood arrangements have been done, blood transfusion has been given 1 or 2 bottles, and then we have to monitor the patients carefully, closely, hourly, pulse, blood pressure, and urine output. And with this, if patient is improving, so it is a non-variceal bleeding, and if we find in the endoscopy that patient has got H. pylori, so eradication of H. pylori, as I have mentioned in my earlier talk, that can be given. Then now comes the management of the variceal bleeding. You know, esophageal varices occur due to high portal venous pressure. So portal vein is formed by the superior vena cava joining the superior vena cava, the splenic vein. This portal vein is formed, and this portal vein goes to the liver, and it branches inside the liver, then unites to form the hepatic vein, and this drains to the inferior vena cava. Now, if there is total hypertension, the esophageal varices will dilate and they will rupture. They can give rise to bleeding. We call it the variceal bleeding. Now you see, this is the spleen. This is splenic vein, and this is superior vena cava. This is splenic vein. This is vein from the lower GI tract. Now there is a combination of these two. This vein unites here, and this forms the portal vein, and then portal vein divides into the inside the liver, and then ramification and forms this hepatic vein, and it then drains into the inferior vena cava. So if there is derangement of this liver by disorder, we call it cirrhosis of liver, then there will be hypertension, portal venous hypertension. There are so many causes of portal hypertension, and this type of portal hypertension and cirrhosis, and another class will be taken. Then details will be discussed there. Now you understand that this is the combination of two veins that forms this portal vein. So the portal venous pressure is reflected to the splenic veins, and there are certain communications in the esophagus and in the rectum between the portal veins and systemic veins, leading to this some varices. So if there is pressure increased, that pressure will be reflected into esophageal varices, and ultimately there will be rupture that will give rise to bleeding of the esophageal varices. So acute variceal bleeding. So in acute variceal bleeding, if we suspect by means of our history that patient has got history of chronic liver disease, ascites, splenomegaly, jaundice, and if there is splenomegaly and jaundice, we can suspect that probably patient is having variceal bleeding, and that should be confirmed by endoscopy. The first step is the resuscitate. If severely anemic, then you give blood, correct clotting abnormalities. That's why vitamin K injection to be given, and this pharmacological therapy, starlipressin and octreotide. These are the two drugs, somatostatin, that will reduce the portal venous pressure and thereby will reduce the variceal bleed. So these drugs to be given, and endoscopic therapy is also important. One important therapy of endoscopy is endoscopic bending or sclerotherapy. I will show one picture later on where endoscopic bending is shown. So this is so variceal ligation, endoscopic variceal bending or ligation, we call it EVL. It is the most widely used nowadays in the treatment of, and it stops 80% of the variceal bleeding. Then there may be other methods, balloon tamponade. If this bleeding is not stopped, an acute emergency, you can put a balloon which has got a rail strip like thing with two balloons in the upper and in the lower. This balloon can be put here in the stomach and one in the esophagus, then it should be dilated so that by this pressure of this balloon, the esophageal varices will stop. This is called Sang's-Stake in Blackmore tube. Then in certain situations, if still bleeding does not stop, you can give surgery. Surgery indicated when endoscopic hemostasis fails to stop active bleeding, if the rebleeding occurs on any occasions in elderly or frail patients and twice in the younger patients. And angiographic embolizations is the other method. Then another thing is there, STIPS, transjugular intrahepatic protosystemic shunt. If there is pressure of the portal vein, as I mentioned, and if we put a shunt from this portal vein and the inferior vena cava or the hepatic vein, the pressure will be transmitted to the hepatic vein. That's why portal pressure will be reduced. This type of shunt is also done nowadays, and it is called TIPS, transjugular intrahepatic protosystemic shunts. This is an expandable metal stent is deployed between the hepatic vein and the portal vein to reduce the portal venous pressure. Then you can give certain drugs, beta blockers, particularly propranolol, can be given to reduce the portal pressure. And if necessary, esophageal transections can be done if there is necessary, very, very rarely cases. So to sum up, upper GI bleeding is the most common cause, and most important cause of upper GI bleeding is bleeding peptic ulcer and esophageal varices, bleeding esophageal varices. Then a patient, when comes with upper GI bleeding, we have to assess the patient whether patient has got severe bleeding, patient has got unstable condition, whether blood pressure has dropped or pulse rate more than 100, that needs or necessitates blood transfusion. We put IV fluid, normal saline, arrangements to blood can be done, and if facility is available, we have to do endoscopy, but endoscopy is done after 24 hours when the patient is stable. And in the endoscopy, if we find that this is a esophageal varice, that can be tackled by endoscopic banding or sclerotherapy as it is necessary. But if it is bleeding peptic ulcer, there are certain therapeutic measures that can be given by endoscopy, and we can take the biopsy if we suspect a cancer or like that. Now I can show you, this is the Sangstein-Balmont tube. You see this tube has got the gastric balloon and the esophageal balloon. This tube is introduced through the mouth, and this gastric balloon is put in the gastric cardia, and it is in the esophagus and is dilated. This is the procedure how the tube is introduced. And this is the picture, endoscopic picture of EVL, endoscopic variceal ligation. You see, these varices are like these bulb-like things, and all these varices are put together, sucked together, and a band is being given so that it cannot bleed. And ultimately, with time, it slaps away, and there is fibrosis, and that heals. So this is an endoscopic picture of endoscopic view of band ligation. So the algorithm is acute GI bleeding, whether ulcer, whether malarious tear. In malarious tear, it is a bleeding due to vomiting, the retching, there is some erosion, and it spontaneously heals. It does not need any treatment except some 1 or 2 conditions. So if it is malarious tear, whether it is active bleeding, then you do endoscopic therapy. If there is no bleeding, no endoscopic therapy is necessary. Then if it is esophageal varices, then endoscopic ligation, IV vasoactive drugs, octreotide or terlipressin as I mentioned. And if it is ulcer, then active ulcer, visible ulcer, and IV PPI therapy plus endoscopic therapy, both is necessary. Then if there is adherent clot, so IV PPI therapy plus endoscopic therapy. There may be some ulcers which may bleed later on. So that should be kept in the mind, that should be treated also. So through endoscopy, there are some sort of treatments also. If the ulcer is a clean base ulcer, then only endoscopic therapy can be given, no IV therapy, PPI is necessary. But flat pigmented spot, here also no IV PPI is necessary, endoscopy therapy. So endoscopy is the most important tool in the management of bleeding peptic ulcer. If it is massive management, whether it is a esophageal varice or it is a bleeding peptic ulcer. So now a short note of malarious syndrome is a signs and symptoms: vomiting, retching, coughing, preceding hematemesis, especially in alcoholic patients, bleeding from the stairs, which are usually on gastric side of the GE junction, stops spontaneously in 80 to 90% of the patients, and it recurs only in 0 to 10% of the cases. Endoscopic therapy is recommended for actively bleeding malarious tears, angiographic therapy, embolization, operative for tears very rarely, but spontaneously it recurs, it heals. So with this, I would like to conclude, but I have got some assessment for you. I have taken two classes. One is peptic ulcer disease, second is upper GI bleeding. So both the classes I have prepared one assessment paper, and that should be given to you. You just note it down, and subsequently I collect the answers from you. So from peptic ulcer disease, question number 1, define peptic ulcer disease. Define peptic ulcers. Question number 2, name 2 important causes of peptic ulcer disease. Question number 3, mention 3 differentiating points between duodenal ulcer and gastric ulcer. Question number 4, mechanism of duodenal ulcer by the H. pylori. Draw the picture. Question number 5, how do you test Helicobacter pylori? Question number 6, mention 2 regimes of eradication H. pylori. Question number 7, name 3 complications of peptic ulcer disease. Question number 8, what are the indications of surgery in peptic ulcer disease? Question number 9, how do you investigate peptic ulcer disease? Question number 10, if you find an ulcer in the lesser curvature, how do you approach to the diagnosis and follow up? This is all from the peptic ulcer disease. Now there are 5 questions from the upper GI bleeding. Question number 1, mention the common causes of upper GI bleeding. Question number 2, how do we assess severe bleeding? Upper GI bleeding, severe bleeding, how do we assess? Question number 3, outline the management in a bleeding peptic ulcer. Question number 4, role of endoscopy in variceal bleeding. Question number 5, how do you prevent recurrent variceal bleeding? Question number 6, mention the causes of lower GI bleeding. That's all.